Patient case, COPD and depression. Richard Taylor is our 54-year-old gentleman who presents to the clinic with a chief complaint of depression and, in his words, a desire to take control of his life again. His history of present illness. Patient states that he has been grappling with depression since his heart attack in 2015. The depressed mood has been consistently present for the last 6 months. He states a lack of interest in his hobbies of building trains. He states that he has feelings of guilt and worthlessness, and he is fatigued. He cannot focus at work, and he does not want to spend time with his friends. He also says the colder weather, holidays, and being alone on his birthday have contributed to his feelings of worthlessness. He denies any insomnia, suicidal thoughts, anxiety, or any signs of bipolar disorder. He had tried citalopram before, and it had been effective. However, he discontinued it due to the side effects of diarrhea and erectile dysfunction. He would like to restart therapy, but without the side effects. He thinks if he gets his depression under control, he will be able to exercise more, maybe stop smoking, and perhaps that will help his shortness of breath. His past medical history: he had an ST segment elevation myocardial infarction in 2015. Last year, he had a COPD with exacerbation. He was treated with antibiotics and a steroid burst and released. He was not admitted to the hospital. Obesity and smoking, and he has a family history that is positive for cardiovascular disease and depression. In his social history, he is widowed within the last year. He is a social drinker and drinks occasionally, but has been drinking more because of the holidays, and he does not exercise. His current medication list is as follows: metoprolol ER or succinate, 50 milligrams once daily. Atorvastatin, 80 milligrams by mouth once daily. Aspirin, 325 milligrams once daily. He uses a fluticasone 100 microgram inhaler, uses that 1 puff twice daily. Albuterol, 2 puffs every 4 to 6 hours as needed for shortness of breath. And he states that he's compliant with his medications. He is also allergic to adhesives. So his prioritized problem list: high is depression, also rated high is COPD, smoking is high, obesity is medium, however myocardial infarction and dyslipidemia are low because they have been treated successfully. His depression is the first problem we will address. The patient took a HAM-D test, or a Hamilton Depressed Rating Scale, and he scored 16, which places him in the moderately depressed category. He also has risk factors for depression, for example, loss of a spouse, depression due to a chronic illness, and a family history. In his current assessment of drug therapy, he is not receiving any treatment. He did in the past take citalopram, and it was effective. However, he discontinued it due to side effects. Per the APA and AAFP guidelines, the patient should be on an SSRI or an SNRI, along with either cognitive behavior therapy or just as monotherapy. I recommend for this patient both psychotherapy or cognitive behavior therapy and an SNRI like bupropion. I would start him on 150 milligrams SR bupropion once daily in the morning for 3 to 5 days, and then go to twice a day dosing depending on how he tolerated the medication. My rationale for this: it is less likely to cause erectile dysfunction and GI side effects, and also can be used to aid in smoking cessation. Patient education for this medication. Patient should notify the team if there are any changes in behavior, i.e. suicidal thoughts, or the medication not working after 4 to 6 weeks. He should take the medication at least 8 hours apart from the first dose in the early afternoon, not too close to the evenings because it can affect sleep patterns. He should not crush or chew the tablet since it is extended release. He needs to avoid alcohol while on bupropion. One, because there's an interaction between bupropion and alcohol, and also because alcohol worsens depressive symptoms. We should counsel the patient that treatment for depression can be long-term, so he might be on therapy between 6 to 12 months, or maybe longer, depending on how he responds to his therapy. And we should encourage him to consider smoking cessation. Mr. Taylor's second problem is his COPD. His assessment of disease is that he has no visible signs of breathlessness upon rest, but complains of mild shortness of breath upon exercise. He has no bronchitis. His CAT score is 21, which indicates a high impact on his quality of life or everyday living. His FEV1 over FVC, which is forced expiratory volume per second over forced vital capacity, was 0.63. And per GOLD guidelines, if it is less than 0.7, it indicates a restricted airflow in the lungs. Per GOLD guidelines, his MMRC dyspnea scale was mild. His current drug therapy, therefore, for COPD is not effective. The short-acting albuterol is not controlling symptoms, and per new GOLD algorithm, a long-acting beta agonist may be a better option for this patient. My recommendation for this patient we would consider either a once or twice daily long-acting beta agonist along with an inhaled corticosteroid, a dual inhaler. For this patient, I would choose fluticasone or vilanterol once a day. And my rationale for this is that he's already taking once-a-day dosing on his other medications. We would only add to the adherence by having him take everything in all his medications at one time. Also, the combination of a long-acting beta agonist and inhaled corticosteroid has been shown to improve lung function and reduce symptoms. I would also discontinue the patient's fluticasone since we'll be adding the inhaled corticosteroid in the dual inhaler. But I would keep the albuterol inhaler on board for emergency breathing treatments if he needs it. Monitoring for this patient would include spirometry, his CAT score changes, and dyspnea index. For this patient, counseling must and should include smoking cessation. We must encourage him to stop smoking since smoking exacerbates COPD. He will already be on the bupropion, and if successful, he can use that to aid in smoking cessation. However, if he needs an additional tool, feels like the bupropion gives him strength to stop smoking but not quite enough, I would suggest the nicotine gum or lozenges. I would not suggest the patch because of his allergy to adhesive unless we were willing to try a skin test and if the patient was willing to try that. While on the inhaler, we must remind the patient he must always rinse and spit after use to prevent any development of thrush, and we should always counsel him on appropriate inhaler use when he comes to the office. He should also watch for changes in heart rate, and that would occur because of the long-acting beta agonist, and he would notify his care team should that happen. Thank you.